because the likelihood of protection from disease was based on immunogenicity data in the absence of vaccine efficacy data. There's no established correlate of protection, and demonstration of effectiveness for vaccine licensure was based on a surrogate endpoint reasonably likely to predict clinical benefit, and results will require post-licensure vaccine effectiveness studies to confirm the results. The overall certainty of the evidence for serious adverse events and arthralgia arthritis was low. Certainty was downgraded for individual safety outcomes because of various serious imprecision related to the small sample size, because the confidence interval around the effect estimates indicated the potential for possible benefit or harm from vaccination, or because of indirectness related to a suboptimal method for collection of specific outcome information. Although we assume results will be similar when the vaccine is used in larger populations, real-world data would be important to confirm the safety profile available from the clinical trials. For Domain 3, values, 2 studies informed the workgroup's response on the extent to which the target population feels the desirable effects of vaccination are large relative to undesirable effects, and if there is important variability in how much people value the main outcomes. The first study was an online study conducted in 2022 with questions prepared by CDC staff and which considered perceptions of a chikungunya vaccine among US adults. Participants were provided with information on risk for disease with travel during outbreak or non-outbreak periods, rates of chronic arthralgia after disease, and a hypothetical vaccine cost. Results showed that during an outbreak period, defined as a traveller having a 1 in 150 risk of disease, the likelihood respondents would receive the vaccine was very or somewhat likely in 42%, shown in green, very or somewhat unlikely in 32%, shown in blue, and unsure in 26% in grey. During a non-outbreak period, defined as a risk of disease of 1 in 15,000, the likelihood respondents would receive the vaccine was very or somewhat likely in 27%, very or somewhat unlikely in 49%, and unsure in 24%. There was variability in responses with a lower likelihood of vaccination among persons aged 18 to 29 years compared with adults in older age groups, among those with lower education and household income levels, and people of black race were less likely to be interested in being vaccinated than those in other race or ethnicity groups. Consistent with results for the high and low risk scenarios, the most important factor considered by respondents in making a decision on vaccination was the risk of disease. Also important for many respondents were the risk of vaccine side effects, the chance to avoid possible long-term joint pain through being vaccinated, and vaccine cost. The second study was an online survey funded by the vaccine manufacturer and conducted in 2021 among approximately 2,000 US residents aged 18 years and older who had travelled internationally during the last 3 years or plan to do so within the next 3 years. Limited information about participants was provided, but anyone who self-identified as anti-vaccination was excluded. After being provided basic information on chikungunya and its sequelae, 72% were very or somewhat likely to ask a healthcare provider about a vaccine, and 80% were very or somewhat likely to be vaccinated if the vaccine was recommended by a healthcare provider. Although there were substantial limitations of both of these studies, overall, the workgroup determined that it is likely US travellers will have variable opinions on whether the desirable effects of vaccination are large relative to the undesirable effects. And there will likely be important variability in how much people value the vaccine, with level of disease risk a key factor in determining likelihood of vaccination. The workgroup noted that clinicians should allow for discussion of individual values and preferences in their discussions on vaccination against chikungunya. Domain 4 was on acceptability of chikungunya vaccine. In considering acceptability, the work group thought that key stakeholders were US travel medicine and other healthcare providers and travellers. In regards to travel medicine and other healthcare providers, an online survey in 2021 funded by the vaccine manufacturer and conducted among 158 US healthcare providers who routinely provide travel health services found that 80% were very or somewhat likely to recommend the vaccine if it was recommended by ACIP. For travellers, vaccine recommendations are expected to be acceptable because vaccine availability gives an option, in addition to mosquito bite prevention measures, for protection from a disease that can cause severe arthralgia and potentially long-term joint pain. The work group therefore thought the intervention would be acceptable to key stakeholders. In Domain 5, the work group considered if chikungunya vaccination is a reasonable and efficient allocation of resources. A cost-effectiveness analysis for chikungunya vaccination of travellers has not been conducted. Most travel vaccines are not cost-effective, and chikungunya vaccine for travellers is not likely to be cost-effective because the number of US travellers needed to be vaccinated to prevent one case is high. However, the work group noted that cost-effectiveness considerations are less relevant for a travel vaccine because the decision on vaccination is for an individual traveller and not being made for the population, so broad resource allocation decisions are not being made. And because the vaccine is typically paid for by the traveller themselves and is often not covered by insurance. The work group also noted vaccine recommendations targeted to higher risk groups are probably an efficient use of resources, as the financial implications of vaccine purchase will be borne by travellers most at risk of a disease or severe outcomes, who will therefore receive the most benefit. The work group therefore determined that chikungunya vaccination is probably a reasonable and efficient allocation of resources if chikungunya vaccine recommendations are targeted to higher risk groups. In Domain 6, we considered the impact on health equity. Chikungunya vaccine will probably have to be paid for out of pocket by most travellers, and some travellers will have resources to pay for vaccine and others will not. In addition, travel medicine providers are likely to have a better awareness of chikungunya disease and vaccine availability than non-specialist providers, but people with fewer resources are less likely to attend a specialist travel medicine provider. These issues might cause health disparities, but the work group noted that the chikungunya vaccine recommendations cannot address these issues. The work group's conclusion was that health equity would probably be reduced by chikungunya vaccine availability, but the issue cannot be addressed within the context of the vaccine recommendations. For the final domain, we considered the feasibility of implementation of chikungunya vaccination. The work group noted the vaccine has a single-dose primary series, which should allow for easy administration during a pre-travel consultation.
Right? I know, you're going to talk.
One topic the work group discussed was that disease risk is highest during outbreaks, and vaccination will be of most benefit for travellers during an outbreak. However, a challenge might be a delay in awareness of an outbreak, with travellers potentially exposed during high-risk periods in the early stages of an outbreak. To address this as best as possible, CDC will post information on outbreaks on the CDC website as soon as we become aware of outbreaks. Although we discussed this as a challenge, most of the work group members did not think it would be appropriate to address the issue by recommending vaccination to every traveller travelling to any destination with risk of chikungunya, because there would likely be an adverse risk-benefit assessment given the variable and often very low risk for travellers, and because of the substantial differential between risk during outbreaks and at other times. The decision overall was that vaccination is probably feasible to implement. Overall, when considering all the domains of the evidence to recommendations framework, the work group determined that the desirable consequences probably outweigh the undesirable consequences in most settings. And now I'll present the draft recommendations prepared by the work group for ACIP's consideration. Our draft recommendations for the live attenuated vaccine currently under consideration by the FDA for licensure are that chikungunya vaccine is recommended for persons aged 18 years and older travelling to a country or territory where there is a chikungunya outbreak. In addition, chikungunya vaccine may be considered for the following persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. The groups are older persons, for example, older than 65 years, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, and persons staying for a cumulative period of 6 months or more during a 2-year period. To provide data to support our primary recommendation for vaccination for persons travelling to a location where there is a chikungunya outbreak, I'll provide an example from US traveller chikungunya data from 2023. As you might recall from a presentation I gave at the June ACIP meeting, there was a large outbreak of chikungunya in Paraguay during 2023. On the left, you'll see a graph that shows that among all US travellers to destinations with risk of chikungunya, fewer than 1% travel to Paraguay. However, on the graph on the right, you will see that among all US traveller chikungunya cases reported to date during 2023, 26% of them, or 18 of 69 cases, have been among persons who travelled to Paraguay. These data clearly demonstrate the substantially higher risk for travellers during an outbreak. To clarify what is meant by an outbreak in the language of the recommendations, an outbreak will be defined as occurring when CDC posts information on an outbreak on the CDC website. As I noted earlier, a notice will be posted as soon as CDC becomes aware of an outbreak. A similar process is used for cholera and in relation to the cholera vaccine recommendations, with information posted when cholera outbreaks occur. I also wanted to provide some additional explanation about the second part of our recommendations, or the shared clinical decision-making component. And as a reminder, this is chikungunya vaccine may be considered for the following persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. Older persons, for example, older than 65 years, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, and persons staying for a cumulative period of 6 months or more during a 2-year period. For these groups, there is definitely more uncertainty in the risk-benefit assessment. However, there are likely to be circumstances when some individuals might reasonably choose vaccination, or some providers might wish to recommend it. I'd like to explain the workgroup deliberations around noting older persons, particularly those with underlying medical conditions, should be considered for vaccination, and to provide some data supporting the inclusion of this group. Among adults, the key risk factors for severe chikungunya disease are older age and underlying medical conditions. Similarly, for chronic arthralgia, risk factors include older age and the presence of pre-existing joint problems, which is more likely in older persons. The risk for higher morbidity and mortality in older persons is supported by data from the recent outbreak in Paraguay. Although overall risk for hospitalisation and death from chikungunya is low, there is a markedly higher risk for older persons. The graph shows data by age group, with the number of hospitalisations in the blue bars and the case fatality rate in the dark blue line. The data clearly point to the higher risk for hospitalisation and death in those over 65 years. The workgroup did discuss a broader recommendation for vaccination for any adult with a medical condition. However, with more than 50% of the US adult population having an important medical condition, such as hypertension, diabetes, or heart disease, that would be a very large population for a recommendation, And in relation to that, we discussed the importance of having additional data from post-marketing surveillance to confirm the vaccine's safety profile. Therefore, most work group members thought the best approach was to restrict our recommendation in a non-outbreak setting when risk is often low to those over 65 years of age, particularly those with underlying medical conditions. The second group, noted as a group for consideration of vaccination based on shared clinical decision-making, is travellers who have a cumulative period of travel of 6 months or more during a 2-year period. The key risk factor for chikungunya virus infection among travellers is the intensity of transmission, far more so than the duration of travel. However, if there is equivalent transmission in different areas, then the cumulative duration of exposure becomes important. Additionally, even though a destination might be a low-risk environment overall, transmission patterns can be unpredictable over the longer term, and over a 6-month period, there is likely to be some seasonal variation in mosquito activity that might impact risk. Therefore, the work group considered a shared clinical decision-making recommendation for this group also was appropriate. The 2-year period is based on immunogenicity data showing a high seroresponse rate of 99% at 1 year after vaccination, which suggests there should be good protection from vaccination at least through the 2nd year, but we do not have any longer-term data at the current time. I would also like to explain why the recommendation refers to evidence of chikungunya virus transmission among humans within the last 5 years. The rationale for the timeframe is that given the challenges and deficiencies in surveillance, a 5-year timeframe provides an interval that allows reasonable confidence that there is transmission in a certain location, or conversely that there is insufficient transmission for there to be a concern for travellers. The tool to provide this information will be a map which shows countries with reported chikungunya virus transmission among humans during the last 5 years, which will be posted on the CDC website. And a mock-up example is provided there on the slide. To describe one final point, the recommendation refers to moderate exposure. Text will be provided within the recommendations that indicates moderate exposure could include travellers who might have at least 2 weeks cumulative of exposure to mosquitoes in indoor or outdoor settings. And it does not include travellers who might have limited exposure to mosquitoes. For example, those travelling for business and likely to be mainly in mosquito-protected indoor settings. In conjunction with the recommendations, there will also be language noting travellers should use mosquito bite precautions, and also text in a table outlining the factors that need to be considered in the healthcare provider and traveller discussion about chikungunya vaccination. I won't read this text, but it was provided in the background materials. So these are our complete recommendations for ACIP's consideration, and I will hand back to Dr. Lee.
Thank you very much, Dr. Hills. This presentation is now open for questions. Dr. Paling.
So first of all, let me just say thank you. This vaccine's never been reviewed, and this is enormous amounts of work. And when people do get chikungunya, they get very sick. And so I recognize the importance of this vaccine. I also really appreciated the explanation of the morbidity and mortality with this illness with age. My question is a request to be reminded about the clinical trials. Can you remind us of the age groups that were included in those clinical trials? Thank you.
Yes, thank you for that question, Dr. Paling. So for the randomised control trial, the age groups included persons from 18 years to over 65 years. I think 91 was the oldest. In the immunogenicity subset, there were 59 subjects in over 65 years of age in the randomised control trial. in the lot-to-lot consistency study was among persons aged 18 to 45 years, I believe.
Thank you. I just wanted to make sure we had data on the immunogenicity of the elderly, and I feel reassured with that. Thank you.
Thank you, Dr. Cotton.
So I just want to be clear, for immunocompromised, this is a attenuated but replicating virus, so similar to measles, yellow fever, varicella. That's correct, right?
It's a live attenuated vaccine, and we anticipate immunocompromise will be a contraindication to vaccination.
Okay. Along those lines, I guess if we're going to recommend it for older persons, it looks like there weren't that many people in the over 65 cohort, and I do have some safety concerns about a replicating virus, especially as we age. We have, diminished ability to clear viruses and whatnot. So I guess I have some concerns about whether we should make that recommendation. Maybe we should review the data on people over the age of 65. It looks like maybe there were just 59 in perhaps the trial you're mentioning. So before we make a recommendation, we might want to just look hard at that safety data. It looks like there were no significant safety concerns, but I have concerns. Certainly we've learned a lot during the COVID-19 pandemic. I've learned a lot about immunocompromised people in their 70s and 80s, and that the immune system wanes with age. So I just have some safety concerns. Thank you.
Thank you very much for that question. Could I have slide 83, please? Thank you. Yes, indeed, that's an important question, and the work group did consider that very closely. This graph shows data by age group with a percentage of subjects with arthralgia represented by the height of the bars and the severity illustrated by the colours, blue's mild, grey's moderate, pink severe, and the rate of arthralgia and the severity of arthralgia after vaccination didn't increase with age. However, it is an important point, and we will be interested with the FDA assessment when it's licensed, as well as ongoing monitoring safety of the vaccine. Thank you.
Thank you. That's a very nice slide, and actually shows a good number of people in the 65 and older cohort. So thank you very much.
Thank you. Dr. Daly?
Yeah, two quick questions. One was a follow-up question from what Dr. Cotton asked. So I was going to ask a similar question, but related. What's known about clearance in natural infection, and what's known about clearance in vaccination? And is sort of persistence of infection related to arthralgia? And then I have a second question.
The virus is cleared fairly rapidly. In relation to the arthralgia, it's not definitively determined, but it's believed it's more an immunologic issue. There has been situations where RNA has been detected in the synovial fluid longer term, but in general, it's considered it's probably more an immunologic response rather than persistent. It's a virus.
Okay, thanks. And then could you put up the draft recommendations just for clarification?
Can I have slide 67, please?
So I'm assuming that there's an or between the second bullets, meaning age over 65 or 6 months.
Thank you for that clarification. We'll add that.
That's true. Okay, thanks. Bye.
Thank you. Ms. McNally?
I have two questions. What is treatment for chikungunya? And my second question is, do we have any information about the cost of this vaccine? Thank you.
So there is no treatment for chikungunya, no specific antiviral treatment for chikungunya. So management is typically with fluids, rest, use of medications for fever and for pain. We do not have information on cost of the vaccine at this time.
Thank you. Dr. Sineas?
Yes, thank you. Given that this vaccine will likely be administered as part of a visit to a travel clinic, do you have any data or information on co-administration with other travel vaccines?
There have been no studies done to look at co-administration with other vaccines.
Well, sorry, just to clarify then, do you believe the guidance will remain silent about it, or do you?
Yes,
anticipate? Okay.
there are no data, so we will just be indicating there are no data.
Okay, thank you. Dr. Cotton?
I guess I would just clarify in that first bullet point about older persons with underlying medical conditions, and I would have some kind of phrasing about making sure they're not immunocompromised, just to make it really obvious. We see all kinds of live viral vaccines being given to people that we wish had not received them. Thank you.
Thank you. Dr. Long?
Yes, it's a typical question here. We're going to say particularly want to give it to those over 65, particularly with underlying medical conditions. Although I think you showed us the immunogenicity data, you, I think, told us that those were much younger people. So will there be any immunogenicity data in older than 65 and with underlying conditions, so that we'll know that it is as immunogenic in that group?
Thank you for that question. So the data in older 65-year-old, the immunogenicity data that have been gathered to date, do include subjects up to about 90 years of age. There's about 60 subjects where those data have been collected for immunogenicity. They were typically healthy for inclusion in the clinical trial, didn't have any serious underlying medical conditions.
Dr. Bell?
Yes, I just, if it's all right with you, Dr. Lee, I think that someone from Valneva might be on the, on the phone, and there have been a couple of issues that they might want to comment on, including the potential cost of the vaccine and this last question that was just asked about additional data in older adults.
Thank you. Please go ahead.
This is Ellen Shannon from Valneva. I can comment on the price question. We do expect that the price of the vaccine will be in line with the other travel vaccines on the market. And there was a second question. I'll refer to my colleague Katrine Dubashar specifically about data in older adults. Was that?
For the chikungunya vaccine at Valneva, we have actually generated some additional immunogenicity data in older adults where the sample goes up to roughly above 100. We continue to see very high seroresponse rates that do not differ from younger adults. And in terms of the population that was studied, I can just support the answer that Dr. Hills gave, that the study population was a generally healthy adult population, but we included also participants with underlying diseases for as long as those were stable and controlled. Thank you.
Thank you. Dr. Paling?
First of all, thank you to Valneva. There are people on this call that do not give travel vaccines on a routine basis. And so it would be really helpful if you would be willing to share a price range. Thank you.
This is Ellen Shannon from Valneva. We are going to be in line with a previous presentation by Dr. Hills. She had presented to the ACIP in June, and it was in the range of her analysis, approximately $350 cost to the patient, or in that vicinity, slightly less.
Thank you. Are there any additional questions? Okay. Why don't we move on to the next presentation, also Dr. Hills, regarding the evidence to recommendations and proposed policy options for chikungunya vaccine use among laboratory workers.
Thank you very much, Dr. Lee. So I'm again going to start with a brief reminder of general considerations for laboratory transmission of chikungunya virus before starting on the evidence to recommendations for chikungunya vaccine use among laboratory workers. At least 44 cases of chikungunya virus infection in laboratory workers have been reported worldwide during the last 50 years. 43 were cases of overt disease, 1 was an asymptomatic infection, and there were no deaths. In regards to US laboratorians, 4 disease cases have been notified in the 8-year period since chikungunya became a nationally notifiable disease in the United States in 2015. However, the identified cases likely underrepresent all infections in laboratory workers, as there is no formal laboratory surveillance system for reporting these events. Documented routes of transmission of chikungunya virus in the laboratory have been through the aerosol route and the percutaneous route. Among cases of percutaneous transmission with more detailed information available, 2 researchers experienced a needle stick injury while they were working with and injecting mice, and for a 3rd case, a researcher experienced a forceps prick while dissecting mosquitoes infected with chikungunya virus. Transmission through accidental mucosal exposure is also possible. The policy question the workgroup considered was, should chikungunya vaccine be recommended for laboratory staff at risk for chikungunya virus infection? I'll note that the same grade assessment for outcomes of vaccination was used for laboratory workers as was used for travellers, so I won't present the grade results again. However, when discussing laboratory worker recommendations, the workgroup did specifically discuss the topic of cross-protection provided by vaccination against the 3 genotypes of chikungunya virus, given laboratory workers might be exposed to high titers of a specific genotype. We noted there are only very limited data from laboratory studies to confirm cross-protection. However, we also noted that although there are multiple genotypes of chikungunya virus, they are generally considered to constitute a single serotype, and the differences in antigenicity are relatively limited. There is also no evidence of reinfection in humans with different genotypes. For the first domain of the ETR, the workgroup determined that chikungunya can't be considered of public health importance overall, as there are only occasional cases reported among US laboratory workers. However, for laboratorians working with the virus, there is the potential for acute infection with severe polyarthralgia and the possibility of chronic arthralgia. For values, we considered that scientists are likely to consider the desirable effects of vaccination are large relative to the undesirable effects, and there is unlikely to be important variability because they will likely understand the risks of disease and risks and benefits of vaccination, and most scientists value vaccination. Chikungunya vaccine is likely to be acceptable to key stakeholders, including occupational health directors, laboratory managers, and laboratorians, as its availability will improve laboratory safety. For resource use, the workgroup felt that chikungunya vaccination was a reasonable allocation of resources because vaccination recommendations will be for a limited number of staff undertaking research or specific diagnostic work. And paying for vaccination is a small cost for administrators to pay to avoid the substantial impact and costs of a worker becoming infected. We thought that equity would probably be increased because if employers offer chikungunya vaccination to laboratory staff, it will improve safety for workers and address an occupational health issue. And finally, we thought that vaccination was feasible to implement as it will likely be incorporated into existing occupational health programs for laboratory workers. Overall, when considering all the domains of the evidence to recommendations framework, The work group determined that for chikungunya vaccination for laboratory workers, the desirable consequences probably outweigh the undesirable consequences in most settings. And our draft recommendation for ACIP members' consideration is chikungunya vaccination is recommended for laboratory workers with a potential for exposure to chikungunya virus. The recommendations will be presented with additional text to provide clear information for implementation, including noting that a local institutional biosafety committee should undertake a risk assessment of the potential for exposure to chikungunya virus for each laboratory worker working with the virus, considering the type of work to be performed and the biosafety level at which work will be conducted, and that vaccination is not necessary for workers handling routine clinical samples who should routinely use standard practices for handling patient samples. So again, our draft recommendation is chikungunya vaccination is recommended for laboratory workers with potential for exposure to chikungunya virus. And I will hand back to Dr. Lee for any questions.
Thank you. Dr. Grogg?
Yeah, this is Stan Grogg, and I've got a travel medicine certificate from ISTM. But we take mission teams to different areas of the world. In the 6-month time period, I didn't get my hand up in time, but the 6-month time period seems a little bit unusual. It only takes one mosquito bite to give you chikungunya, and I've seen chikungunya in a lot of areas, Haiti and Nicaragua, that again, 6 months, I think it should have been expressed more if you're out in the countryside for any particular short time period, you could be exposed to chikungunya pretty easily. Thank you.
Yes, thank you for that question. So you're correct that it takes just one mosquito bite, but it needs to be an infected mosquito. And what we do see is that there are millions of travellers to areas with the risk for chikungunya virus transmission each year. And we really only see 100 to 200, as I said, reported cases. This year, we've seen about 70 cases of chikungunya virus transmission. So when the work group had these discussions, we were really trying to weigh up the benefits of vaccination with the benefits in terms of protection from disease with the risk-benefit assessment in terms of the risks and need for vaccination. We wanted to provide a time period to provide fairly clear advice for healthcare providers, unlike you, Dr. Grogg, who has a certificate from the ICM. A lot of healthcare providers are not familiar with chikungunya virus. In fact, in a survey that the manufacturer did, only 50% of travel medicine providers were described themselves as familiar with chikungunya. So we're trying to weigh up that, and we didn't really want to specify the location either, just because the Aedes aegypti mosquito is a very domestic mosquito, so it can be found around homes. It breeds in containers like the base vases, the base of flower pots in trash that's lying around, so it can be very high intensity in urban areas, unlike some of our other diseases like Japanese encephalitis, for example, that are more risk in rural areas. So yeah, that's sort of the thinking the work group went through to get to our traveller recommendations.
Thank you.
Thank you. Dr. Paling?
So thank you for this presentation, and thank you. I agree with you that having this option for laboratorians that work with this virus makes sense. A clarification that would help me understand the feasibility and equity is when a vaccine is recommended for occupational health these people that are exposed, is it covered by the employer, or does the employee have to cover the expense of this vaccine? Thank you.
Thank you, Dr. Paling. As I understand it, in many, if not most cases, it is covered by the employer. So CDC, for example, pays for the vaccine. We do have a member on our work group who does work in a research facility that uses a vaccine, and I understand they pay for the vaccine. I can't definitively comment on every institution, but I do believe most places will pay for it.
Thank you. Dr. Cotton?
For this language, I was wondering if we should put in front of laboratory workers non-immunocompromised. I don't know if that's appropriate or if it would just be in the fine print, but I would want to emphasize, you know, an estimated 3% of the US population is immunocompromised, and you wouldn't want someone to accidentally get this. Thank you.
Thank you, Dr. Cotton. I will note that there will be in the MMWR a very clear section that has the contraindications. We are waiting for the FDA's licensure of the vaccine just to confirm what they are, but certainly it's an important point with a live attenuated vaccine.
Thank you. Are there any additional questions for Dr. Hills? And particularly if any members would like to make a comment about the recommendation language for the next meeting. Dr. Talbot.
Yeah, I just was hoping for clarification about coverage, because we had this large discussion for rabies, and techs who worked in veterinary offices did not have their rabies vaccines covered. And that was one of the issues we had with the vaccine. So I'm not sure how this is different. And it does make me worry that it needs to be covered by employees.
Dr. Hills, I'm going to ask to see if somebody from SHE is on. Is Dr. Marotra on still? Okay. Dr. Hills, I'm sorry, I apologize for interrupting. Is there, I don't know if you have any additional response in terms of, I don't believe ACIP directs the coverage of employers, but if there's any additional information you can provide, that would be helpful.
Yeah, thank you, Dr. Lee. I do not have any additional information. I don't think we can address that in the context of our recommendations, but definitely is an important point, and it will clearly be indicated that it is recommended for people who are at risk for potential exposure, but I cannot directly address the question on payment.
Thank you. Dr. Cotton?
I'd just like to second Dr. Talbot's point. This is an area, laboratory workers, especially microbiology workers, that has really been decimated from the pandemic. Staffing issues are quite significant. So I'd like to just lend support for advocacy in protecting them with vaccines that hopefully could be covered optimally by their workplace or other modalities. I don't know if there would be a program for vaccination of laboratory workers, but something along those lines, because it really is a vulnerable population, and many of us are really suffering by the short staffing in those areas, and many of our patients are impacted by that. So if we could better protect them, we could perhaps better protect American healthcare. Thank you.
Thank you for that comment. It definitely is an important issue.
Dr. Hills, as a way to follow up on that, are there any, I recall surveys in the past just to understand what the practices were, but would there be opportunity for any planned surveys to understand coverage, just to monitor whether or not there are any access and equity issues, essentially?
Yeah, thank you for that suggestion, Dr. Lee. It's not an area I'm familiar with, but we can certainly look into it further and see if there is any information available.
Thank you. Yeah, or any surveillance systems or anything that might be able to shed light into whether or not adoption is happening in the future. Well, with that, I just want to thank you, Dr. Hills, for the tremendous amount of work you just presented and very efficiently, and Dr. Bell also for your presentations on chikungunya vaccine. We will move on next to a brief update, I believe, by Dr. Wilbur Chen, who is the work group chair for dengue vaccines. Dr. Chen, I don't know if you have slides, but if you have a dengue vaccine update for us, we'd appreciate it.
Yes, and I believe my slides are up. So let's go to the next slide. So let me just remind you that dengue presents a significant public health problem to areas that suffer from the burden of endemic dengue. And dengue is endemic in United States territories like Puerto Rico, Virgin Islands, American Samoa. But it's not endemic to the continental US. Next slide. So Dengvaxia, which is manufactured by Sanofi Pasteur, was the first dengue vaccine licensed by the FDA. It was approved in May 1st, 2019. The ACIP developed recommendations for Dengvaxia in June of 2021. You can see the recommendation language there on the slide. I won't read it myself. Next slide. So Takeda had a dengue vaccine candidate, TAC-003. It was the second vaccine that was under review by our work group. It's been in review since August of 2022. The dengue work group presented to the ACIP on 3 different occasions: October 2022, February, and June of this year, 2023. In October 2022, we reviewed the dengue epidemiology and reviewed the Sanofi dengue vaccine, and then the ACIP recommendations that had been approved. In February of this year, Takeda presented their data on the safety and efficacy of the vaccine, and the work group also provided a summary and an interpretation of the data that was presented. Then in June 2023, the policy questions, economic and cost effectiveness analyses, and a partial evidence to recommendations framework were presented. And for today's meeting, we had intended originally to present the draft recommendations and full evidence to recommendations framework. Next slide. So I'll just remind you, there was a pivotal efficacy study. It was a phase 3 TIDES trial. It was designed for the primary endpoint for virologically confirmed dengue, or VCD. Among seropositives, you can see there is protection that is documented for all 4 serotypes of dengue, for both VCD, but also for another endpoint for hospitalization, a more severe endpoint. Next slide. Now let's look at the seronegatives. Among seronegatives, protection is demonstrated against serotypes 1 and 2. You can see there in the box. Next slide. But then when you look at the seronegatives, there's no efficacy that we documented against serotypes 3 and 4. The data were insufficient to rule out increased risk of VCD among vaccinees, in fact, because of the very low numbers of events. Next slide. When evaluating hospitalizations as an outcome, the more severe measure, among seronegatives, there were low numbers of events. Efficacy was not demonstrated for serotype 3, and there was only a single hospitalization event for dengue serotype 4, so efficacy is really not known. Next slide. So if you look at the global stage, the European Medicines Agency, in cooperation with the World Health Organization, they provide reviews for markets outside of the European Union, and it's a procedure that they call the EU Medicines for All, or the EU M for All. On October 14th, 2022, the Committee for Medicinal Products for Human Use, CHMP, of the EMA provided a positive opinion, and they recommended the approval of TAC-003 for the prevention of dengue disease caused by any serotype in individuals 4 years of age and older in Europe and in dengue endemic countries participating in this EU M4A procedure. December 8th, 2022, the European Commission granted marketing authorization for TAC-003, and thereafter its trade name is Qdenga. And since then, TAC 003 has been approved in the EU, UK, and Brazil, Argentina, Indonesia, and Thailand as well. Next slide. So here in the US, July 11th, 2023, Takeda announced that they voluntarily withdrew its biologics license application from the FDA. Their reason was that the FDA had requested for additional data, which was not collected in the pivotal efficacy study, the phase 3 TIDES trial that I showed you in earlier slides. Next slide. Meanwhile, the WHO SAGE, Strategic Advisory Group of Experts on Immunization in September, developed recommendations and recommended that TAC 003 be considered for introduction in settings with high dengue disease burden and high transmission intensity to maximize the public health impact and minimize any potential risk to seronegative persons. SAGE also recommended that the vaccine be introduced to children aged 6 to 16 years of age, and within this age range, the vaccine should be introduced 1 to 2 years prior to the age-specific peak incidence of dengue-related hospitalizations. So that's just kind of when it should be launched in those populations. The vaccine should be administered in a 2-dose schedule with a 3-month interval between the 2 doses. SAGE recommended that vaccine introduction be accompanied with a well-designed communication strategy and community engagement, which is important for all dengue vaccines to be launched. And then they also recommended post-authorization studies should be conducted to further study vaccine effectiveness and safety against serotypes 3 and 4. Okay, next slide. So the future plan for TAC 003 in the US is going to be further evaluated by Takeda, but as of now, the ACIP dengue vaccine work group will be paused until the BLA for TAC 003 is resubmitted to the FDA, or a new dengue vaccine is submitted to the FDA review for the work group to consider. Next slide. So I really wanted to tell you about this pause in our work group. I also wanted to take this opportunity to thank the work group CDC leads, Drs. Gabriela Paz-Bailey and Laura Adams. I also wanted to thank the many CDC contributors, our consultants who have been just tremendous in giving us their opinions, the ex officio members, liaison representatives, and certainly my co-ACIP members who have provided their service and contributions to this work group. Thanks very much.
Thank you very much, Dr. Chen. Are there any questions for Dr. Chen or other work group members? Dr. Long?
I wonder if you can tell us if the uptake of the previously recommended vaccine for 9-year-olds who are seropositive has increased from what was woeful infrequent?
So I think I can direct that question to Dr. Paz-Bailey, who could perhaps tell us about the rollout in Puerto Rico.
Yes, Dr. Chen, can you hear me?
Yes, we hear you well.
Thank you. Yeah, implementation of the Imvaxia has been complicated, first because we started during the COVID vaccination campaign, and second because we had to set up the laboratory procedures for pre-vaccination screening, and a 2-test algorithm is required. Implementation is still slow, and so far 100 doses of the vaccine have been administered. Dr. Long.
Thank you. Dr. Cotton?
Dr. Chen, I have a question. If this vaccine will be available in other places, what will your recommendation be for patients that you might see in clinic who are going to live somewhere where the vaccine is available, but it's not an approved vaccine in the United States?
So the simple answer is they will not be able to obtain it. It's not FDA approved. If they have that planned travel internationally, they could seek it out. It requires a lot of effort, of course, to seek it out at an international site, perhaps even at the place in which they might be temporarily emigrating to try to get that vaccine administered as early as possible. But that's really the situation. Yeah.
Any additional questions? Well, we want to thank the work group for all of your incredible work and recognize you'll go on pause, but hopefully we will be able to see this come back again one day soon. With that, we are going to take almost the full break. My members are going to be astonished. We're going to go until 55 minutes after the hour, and then we'll reconvene for our COVID-19 vaccine session. Thank you, everyone. It's now 55 minutes after the hour. I want to welcome everyone back to the ACIP meeting for today. And we will start with the next session on COVID-19 vaccines. Dr. Matt Daly, who is the work group chair for the COVID-19 vaccines work group, will provide an introduction and overview of today's session.
Thanks very much for that, Dr. Lee. So I'm Matt Daly, and I'm the ACIP COVID-19 vaccines work group chair. Next slide, please. That's not for me. Sorry, there's applause in the room. So in terms of COVID-19 vaccine updates, on September 11th of 2023, the FDA authorized the updated mRNA COVID-19 vaccines for use in persons ages 6 months through 11 years of age under emergency use authorizations, or EUAs. In addition, on the same date, the FDA approved the updated mRNA COVID-19 vaccines in persons ages 12 years under a supplemental biologics license application, or BLAs. The next day, ACIP convened, and ACIP voted to recommend vaccination with updated 2023-2024 formula COVID-19 vaccines as authorized under the EUA or approved under BLA in persons aged 6 months and older. And then on October 3rd of 2023, the FDA authorized the updated 2023-2024 formula of Novavax COVID-19 vaccine for use in persons ages 12 and older under EUA. Next slide, please. In terms of the ACIP COVID-19 vaccines work group work since that May 12th meeting, we've met several times. We have reviewed and discussed COVID-19 vaccine safety, including data that Dr. Shimabukuro presented yesterday afternoon and reviewed for us. And then we also discussed a number of important COVID-19 vaccine implementation issues. Next slide, please. So for today, we will first hear from Dr. Shannon Stokely, who will review a number of aspects of COVID-19 vaccine implementation. Following that, we'll hear from Dr. Megan Wallace, who will provide some additional COVID-19 policy updates, followed by a discussion. Next slide, please. I just want to sincerely thank all the COVID-19 vaccine work group members who've been working for years at this. Too many meetings to count, but that includes ACIP members, ex officio and government members, our CDC lead, Dr. Wallace, liaisons, as well as consultants, and thanks to you all. Next slide, please. And then a number of CDC participants who make all of this happen. Next slide, please. So I'll turn this over to Dr. Stokely.
Thank you. So good afternoon, everyone. I'm Shannon Stokely. I'm with the Immunization Services Division, and today I'll provide an update on the implementation for the 2023-2024 COVID-19 vaccines. So next slide. And so I'll start by covering some of the changes with the transition from the U.S. government COVID-19 vaccination program to distribution through the commercial market. Next slide. So as mentioned earlier, the COVID-19 vaccination program, or the federal program, discontinued on September 12th of this year as applied to the bivalent Moderna and Pfizer-BioNTech vaccines, and then on October 3rd as it applied to the ancestral or the original Novavax COVID-19 vaccine. And now all the current COVID vaccines are available on the commercial market. And although the U.S. COVID-19 vaccination program has ended, providers are encouraged to continue administering COVID-19 vaccines at their locations and also participate in vaccines.gov, where they can list vaccine availability at their location. With the end of the federal program, there have been changes to provider agreements and to data reporting. And so now vaccine data reporting has transitioned to routine reporting processes for jurisdictions, and this really applies to immunization information systems and relying on the state policy for reporting to the vaccine registry, but also reporting to CDC. Next slide. So although a COVID-19 vaccine has been commercialized, updated vaccines are available to most people living in the US at no cost through their private health insurance or through Medicare and Medicaid plans. So private health insurance plans that are ACA compliant are required to cover COVID-19 vaccines from an in-network provider at no cost sharing. And then vaccines are also covered under Medicare Part B without cost sharing. And then I think it was mentioned earlier this morning through the Inflation Reduction Act, that eliminated cost sharing for all ACIP recommended vaccines under Medicaid and Medicare Part D. We also have the Vaccines for Children program, which provides vaccine at no cost to children through age 18 years and children who meet at least one eligibility criteria, and that is being Medicaid eligible, uninsured, American Indian or Alaska Native, or underinsured. And then finally, we have the Bridge Access Program, which provides vaccines at no cost to adults aged 18 and over who are underinsured or uninsured. Next slide. Overall, there is an increasing supply of vaccine to meet demand. And as mentioned, all three 2023-2024 COVID vaccines are available. With the place, there have been some reports of initial delays in distribution and questions about adequate supply. So one thing just to mention, when you transition from the federal vaccination program to commercial distribution, they are very different systems. So under emergency conditions with a federal distribution system, millions of doses were distributed within a very short amount of time. But with the transition to the commercial market, distribution of COVID vaccines is now similar to that of routine vaccines. So supply is distributed over time to meet demand rather than all at once. And it's just not going to look the same as how it was under the public health emergency. There were reports of delays in distribution early on and shipments taking longer than expected, but this has significantly improved, and we continue to work with our jurisdictional partners to optimize supply and distribution. And we also continue to have conversations with manufacturers and distributors to ensure timely distribution. Next slide. So now I just want to provide a little bit more information about the Bridge Access Program. Next slide. And so as mentioned before, the Bridge Access Program provides no-cost COVID-19 vaccines to adults that do not have health insurance and adults whose insurance does not fully cover all COVID-19 vaccination costs. All CDC recommended COVID-19 vaccines are included in this program, and the program will continue through the end of December of 2024. The Vaccines for Adults program, which has been proposed in multiple presidential budgets, would be a long-term solution to ensure all adults have access to recommended vaccines, including COVID-19 vaccine at no cost to them, but as we know, that program doesn't exist at this time. So the Bridge Access Program is really critical to fill that gap for or underinsured adults. Next slide. So who can get vaccines through the Bridge Access Program? That includes adults age 18 years and older who are uninsured, meaning they don't have health insurance. They can find free vaccination at any of the participating Bridge Access Program sites, and I'll describe those sites in a moment. Adults age 18 years and older who are underinsured, meaning they have insurance, but the insurance doesn't cover all the costs, such as a copay. They can find free vaccine at participating Bridge Access Program sites, which are in network with their insurance, and that's a really key point to mention. Patients may not have copays waived at Bridge sites, which are not in network with their insurance. And so patients will need to really understand within their insurance plan where the in-network providers are and seek vaccination at those locations. And so this may involve seeking vaccination within a specific health system or within a specific state or a specific set of retail pharmacies or a certain type of provider. And it's important to note that patients do risk receiving bills for vaccination if they accidentally misrepresent their insurance coverage when seeking vaccination through a Bridge Access Program site. Next slide. So I'll talk a little bit more about the Bridge Access Program site locations. And so we are leveraging existing public health infrastructure through jurisdiction immunization awardees and local health departments and HRSA-supported health centers to provide no-cost vaccination to adults without health insurance. Adults without health insurance can get vaccines at HRSA-supported health centers enrolled in their local health department's 317 program and also participating in the Bridge Access Program. And members of federally recognized tribes can also get no-cost vaccines at Indian Health Service, tribal or urban Indian Health Program facilities, regardless of the provider's enrollment status with the Bridge Access Program. And last, we did modify contracts with CVS, Walgreens, and eTrue North to provide no-cost vaccination at these retail pharmacies to adults without insurance and adults whose insurance doesn't fully cover the cost of vaccination. And just of note, eTrue North is a pharmacy aggregator, meaning they enroll smaller and independent pharmacies into the Bridge Access Program. And there also may be community events or pop-up sites with these groups as the season continues. And again, we encourage people to visit vaccines.gov to find a provider near them who is offering vaccine. It is a requirement that all of the participating sites list their vaccine availability on vaccines.gov. Next slide. So I'll just provide a little bit more information about the numbers around the Bridge program. Again, we monitor vaccine doses for the program, both through our pharmacy partners and our immunization program partners. The contracted pharmacies are required to provide to us on a daily basis the number of sites that are operating and how many doses have been administered. And then for our public health partners who receive COVID vaccine doses through CDC, we're able to track the orders, including where they go, the number of providers ordering vaccine, and the number of doses that were ordered. So currently there are over 24,000 contracted pharmacy locations and over 380,000 doses have been administered by these sites. And there are now over 4,400 public health safety net providers that have placed more than 6,100 orders for over 287,000 doses of COVID-19 vaccine using their 317 funds. And nationally, 81% of people without insurance are estimated to live within a 5-mile drive distance to a Bridge Access Program provider. Next slide. And now I just want to say a few words about vaccination coverage for the updated COVID-19 vaccine. Next slide. So here's a snapshot of various data sources that will be used for data reporting. I'm not going to go over every system, but you'll see some of these should look familiar to you. We continue to get data from immunization information systems, from our National Immunization Survey. We'll be getting data for claims data, as well as other surveillance systems. Next slide. So today I'm just going to provide some preliminary data about vaccination coverage. This is from our National Immunization Survey. We have an adult COVID module and a child COVID module that's administered every week. For those not familiar with the NIS, this is a random digit dial telephone survey of cell phone numbers. And vaccination status is self-reported by the respondent. And just to caution that sometimes there may be the potential for overestimation since it's self-reported. But looking at our data for the week of October 8th through the 14th, and for adults 18 and over, we see that an estimated 7% are reported to have received a COVID-19 vaccine. And this is the 2023-2024 vaccine. We also assess vaccine intentions among individuals who have not received a vaccine, and we're seeing about 25% of adults say they will definitely get vaccinated, and about 38% saying they probably or definitely will not get vaccinated. Next slide. We also have data on sociodemographic variables. I know it's maybe a little difficult to see in this slide, but we do find that COVID-19 vaccine was more frequently reported among adults who were older, had health insurance, and had higher incomes. Next slide. So now I just want to show data for children, and this is children through age 18 or 17 years. Again, the time period is October 8th through 14th, and this is parents reporting the vaccination status of their children. And we see that about 2% of children were reported to have received a COVID vaccine. Next slide.
We seem to have lost audio on the Zoom.
We just need a moment. It's okay.
Thank you.
Of course, this happens right now. Is it on? Okay, sorry. So, lastly, we show that a little over a quarter of children have a parent that have said they definitely will get their child vaccinated. Excuse me. And about 38% have a parent that said they definitely will not get vaccinated. Next slide. So just to summarize our vaccination coverage data, again, for children, approximately 2% are reported to have received a vaccine, and 7% of adults have reported to receive a vaccine. That was my last slide, so sorry about that. But happy to take questions afterwards. Thank you.
Thank you. This presentation is now open for questions. Ms. Bata? Ms. Bata, sorry, I can't hear you.
I'm sorry, I didn't hear you call my name. A little distracting right now here in the auditorium. Do we have any status on vaccine supply? In particular, we're seeing it very difficult for our pediatricians to get the Moderna product. So I'm wondering about that, and we have heard reports from some of our community members that they've gone to a pharmacy through the Bridge program and were charged for the vaccine.
I'll have to get back to, my understanding is that vaccine supply is available for ordering even for Moderna vaccine. I'll probably have to talk with you offline specifically for your location.
We'll move on to Dr. Kimberlin.
David Kimberlin, AAP Red Book. 2% of children have received the current version of the vaccine. 40% of parents say they're not going to get their children vaccinated. 7% of adults have received the current vaccine. 40% or so say they're not going to get vaccinated. I don't even really have words for this. I appreciate everything that, you know, the AAP is doing, that ACIP is doing, CDC and so forth to make recommendations, but the recommendations are not being heard. And I would suggest that at some future ACIP meeting, additional detail be provided on communication strategies, not additional adjustments to the current recommendations, but how are we trying to do better as a country to get those recommendations to the people that need to hear them in a way that they want to hear them, and they're receptive to being heard. I don't know what that is, but until we address that issue, it doesn't matter how many recommendations we make. It's simply not going to, it will fall upon deaf ears, as they say.
Thank you. Dr. Stokely, I'm going to keep going. And hopefully you have water on that end. Dr. Paling?
So two things. I wanted to follow up on Ms. Bata's comment because in North Carolina, providers are reporting trouble with both Moderna and Pfizer for the young children. And so I think this is a important issue that needs to be investigated to support people. Because the second is I want to, first of all, thank you guys for the bridge program. I think this is a really important program. I also very much appreciated the commentary that you have to figure out which pharmacy or location is in network. I'll have to tell you, I was unaware that I had a pharmacy that was in network, and I believe many people have been caught unaware by that. And so that is a really important message to help with access. Thank you.
And just, sorry, this is Sarah Meyer. Just to comment on the points that have been made about pediatric vaccination, Dr. Stokely, mentioned this, but from what we're hearing, it's not necessarily a supply issue. It's not necessarily a distribution issue. Although, of course, as alluded to, there have been some things that have had to be worked out through commercialization. I think early on in the rollout, there was a little bit of a delay in getting the Moderna supply, but that has improved. I think what we're hearing about more and more is just how difficult it is for pediatricians to be able to carry these products, to store them, to stock them, just the kind of implementation issues around providing this vaccine. And I think we do have some good updates, which I know Dr. Wallace will be talking about in terms of some of the new guidance that we hope makes it more implementable in the pediatric office, but we are hearing about some of those issues. From the VFC side, we have been continuing to increase the allocations so that states can order more VFC doses, and we have recently published an addendum to our VFC operations guide that gives some additional flexibilities around borrowing and things like that to help further smooth some of the implementation challenges that pediatric providers are facing.
Thank you, Dr. Meyer. Dr. Talbot.
This goes along with Dr. Paling's comment, and it's another plug for vaccines for adults, but the bridge program is amazing. That took a whole bunch of work, but the population that's using the bridge program does not have the time, the energy, the bandwidth to find the pharmacy or the person that can deliver the vaccine. These are the folks that are working 2 jobs and don't have insurance. And so I applaud the work. It was an amazing amount of work, but I just think it further reiterates the need for just standard funding for adult vaccines. So thank you.
Thank you. Dr. Earlier, I'm just going to jump in for a moment and highlight, while I certainly believe that acceptability is a component of the low uptake, I do believe the access issues are real, not just supply though, it's really the whole financial model for vaccination. As these vaccines are getting more expensive, we have to recognize we're asking pediatricians, family practice offices, and now adult practices to bear the cost of vaccines that may not get reimbursed at cost, and also may not, they might lose doses. And particularly since uptake is unpredictable right now, it makes it a challenge to understand how many doses you should stock. So it's kind of a chicken and an egg thing, but I do find this very challenging. Let me just say that the vaccines for children's program, the Bridge Access program, and the vaccines for adult program are unbelievable. And I don't know where we would be without it. And I really appreciate all of the efforts it goes into funding vaccines, because it does make it at least feasible But until we change that model of payment where the upfront cost is borne by the providers, it makes it a very challenging thing to continue to scale up and all the other implementation considerations. I'll just stop there. Dr. O'Leary.
Well, Dr. Lee, you said a lot of what I was just going to say. Primary care is stretched incredibly thin right now. Staffing shortages, financially, a lot of these are essentially small businesses with very thin margins. And with the recommendations for COVID vaccine in particular, essentially very similar to our recommendations for influenza vaccine, trying to vaccinate your entire patient cohort essentially from 6 months on up. That's one thing to do that with influenza vaccine, where the vaccine products are not all that expensive. But when you're talking about a product that's $120 to $130 for your entire patient population, that's a real challenge for these clinicians to purchase that product. So this fragmented system of the way we deliver vaccines is really broken. And as Dr. Kimberlin pointed out, with the difference between what we're seeing, 2%, and what parents would be willing to do, which is close to 60 or 70%, that difference is delivery. So if this product is available in every pediatric and family medicine office and clinicians give a strong recommendation, we're going to get much, much closer to those 50 and 60% numbers that we see, for example, with influenza vaccine, which pediatricians and family docs have been working for years to build up to. So I think, if somehow, I don't know how the pricing was determined for these these products, but that it's really a lot to ask of these clinicians to purchase these very expensive products for their entire cohort when they don't even know if they're going to get paid back. So I will stop there.
Thanks, and sorry to jump in before you, Dr. O'Leary. Dr. Deshawn.
Yeah, hi, I'm Dana Deshawn from NAPNAP, and 25 years as a pediatric nurse practitioner in a primary care office. And I guess I was disappointed that there was not the single dose option for the young children as well. So just that feedback that would be really a great option. Our facility are going to be having the COVID-19, but only in certain locations, mainly just because of the price that's also associated with it. And then having the availability also we've ran into issues with that. I think that we just have to come together with a cohesiveness of all pediatric and family providers with the recommendation, because there are a lot of opinions out there, and we know that families do listen to their providers, and so when we come forward with that certainly is helpful in then addressing their concerns. And then I also would think if there was a availability of funding for those mobile vaccines in vans or whatever to go to those areas, that would be amazing as well. Thanks.
Thank you. And Ms. Hayes?
Yes, Carol Hayes with the ACNM. So I have a friend who's a Kaiser patient in Georgia, and she was unable to get the vaccine because Kaiser could not figure out what the billing code was for it. So, and I had a similar experience in trying to get the vaccine myself when I went to a local pharmacy. They had access to order the vaccine, but they couldn't figure out how to enter it into their system. These large computer systems could not get the right ICD-10s in there. So it's like, I feel like we need to be patient. Dr. Kimberlin, don't freak out that there's a low vaccination rate so far. I really think this is all just a computer glitch that needs to be worked out.
Thank you. Dr. Meyer or Dr. Stokely, is there anything else you'd like to add or comment on? Okay, I don't hear any or see any hands raised. So we will move on to the next presentation. Dr. Megan Wallace will be discussing COVID-19 vaccine policy and next steps.
Thank you, Dr. Lee. Next slide. I'm going to start with a brief update on the current COVID-19 epidemiology. Next. This slide shows the trends in the weighted variant proportion and nowcast estimates in the United States by 2-week increments on the left, and a more detailed breakdown of the nowcast estimates for the first 2 weeks in October on the right. As has been the case for the past few months, there are quite a few SARS-CoV-2 lineages currently circulating, but the vast majority of these are still XBB sublineage variants. Next. The figure on this slide shows the weekly population-based rates of COVID-19 associated hospitalizations by season from COVIDnet. For the purposes of this figure, a season is defined as October through September, so the season covers a full 12 months. Each line color represents a different season, with the most recent season depicted by the green dotted line. As we discussed at last month's ACIP meeting, hospitalization rates tended to be lower this past year than in previous years. However, we typically see COVID-19 hospitalization rates begin to increase in November or December, so it's still too early to predict how COVID-19 hospitalization rates will compare this upcoming respiratory season to past seasons. Next slide. On this slide, we are still looking at the weekly population-based rates of COVID-19 hospitalizations, now stratified by age group over the past year. As we've seen before, the highest hospitalization rates continue to be in those 65 years and older, and this is the group in which the recent increases in hospitalization rates is most apparent. Next slide. The figure on this slide shows the number of weekly COVID-19 new hospitalization admissions over time from the National Healthcare Safety Network. When we look to the far right side of the figure, despite hospitalizations being relatively lower than we've seen at previous points, we are currently seeing over 18,000 new hospitalizations a week. Next. This figure is similar to the one we saw on the previous slide, except now we are looking at the number of weekly COVID-19 deaths. Like hospitalizations, the number of weekly deaths is currently lower than what we've seen in the past. However, we are still seeing over 1,200 deaths a week. Next. Now I'll review the current COVID-19 vaccine policy. Next slide. So as you all know, and as Dr. Daly mentioned in his slides, ACIP met on September 12th to review the available evidence for updated COVID-19 vaccines, which have a monovalent XBB.1.5 component. ACIP recommended updated COVID-19 vaccines as authorized under EUA or approved by BLA in persons 6 months of age and older. This includes Moderna COVID-19 vaccine in persons 6 months and older, Pfizer-BioNTech COVID-19 vaccine in persons 6 months and older, and Novavax COVID-19 vaccine in persons 12 years and older. All anticipated updated vaccines are now authorized or approved, and in the next few slides, I'll walk through the recommendations in more detail. Next. Children in the youngest age group, 6 months to 4 years, without immunocompromise are recommended to receive an initial series of mRNA vaccine with at least 1 dose of 2023-2024 vaccine, and these doses should be homologous. Next. This slide shows an infographic of the vaccine recommendations, which I'll use to walk through the recommendations for each age group. I won't spend too much time on each of these today, but these infographics are available on our interim clinical considerations website. So for children ages 6 months to 4 years, those who are unvaccinated should receive 2 doses of the updated Moderna vaccine or 3 doses of the updated Pfizer vaccine, as depicted on the leftmost part of the slide. Those who are vaccinated, shown on the right of the slide, with 1, 2, or 3 or more doses, should also receive at least 1 or 2 updated doses of mRNA vaccine, depending on which manufacturer they received initially. Next. Next slide. With regard to interchangeability of COVID-19 vaccines, which we know is an important consideration in this age group, we previously had this language in our interim clinical considerations detailing the exceptional circumstances in which a different age-appropriate COVID-19 vaccine may be administered. However, this language was leading to implementation barriers among providers. Next. In response, we've updated our language around interchangeability in our interim clinical considerations to clarify the circumstances under which it's acceptable to administer COVID-19 vaccine doses from different manufacturers. The bolded text represents our changes, so you will note we moved away from the exceptional circumstances language and now simply refer to these as circumstances. We've also provided additional descriptions for what these circumstances can be. The text now reads, COVID-19 vaccine doses from the same manufacturer should be administered whenever recommended. In the following circumstances, an age-appropriate COVID-19 vaccine from a different manufacturer may be administered. The same vaccine is not available at the vaccination site at the time of the clinic visit. The previous dose is unknown. The person would otherwise not receive a recommended vaccine dose, or the person starts but is unable to complete a vaccination series with the same COVID-19 vaccine due to a contraindication. Another important note here is that a VAERS report is not indicated in these circumstances. Next. Additionally, also in an effort to simplify pediatric vaccine recommendations, we have updated guidance for children who transition during the initial COVID-19 vaccination series from age 4 to 5 years, and children who are moderately or severely immunocompromised and transition from age 11 years to age 12 years to receive the age-appropriate dosage based on their age on the day of vaccination. Next. Moving now to the recommendations for people aged 5 years and older. All people aged 5 and older are recommended to receive 1 dose of updated 2023-2024 vaccine. mRNA COVID-19 vaccines are authorized or approved for ages 6 months and older, and Novavax COVID-19 vaccine is authorized for ages 12 years and older. One important caveat to this single dose recommendation that I want to mention is that unvaccinated persons receiving Novavax COVID-19 vaccine should complete a 2-dose initial series. Next slide. This is the visual for the recommendation for those aged 5 to 11 years. Note that the dose may be either Moderna or Pfizer-BioNTech, regardless of vaccination history. And as noted earlier, Moderna's dose is the same for the younger age group. Next slide. This slide shows the recommendations for those aged 12 years and older, for which Novavax is also an option. For Novavax, those that are previously unvaccinated are recommended for 2 initial series doses, while those that have any previous vaccinations are recommended for a single updated dose. While for the mRNA vaccines, it is a single dose regardless of past vaccination history. Next slide. For all age groups, persons who are moderately or severely immunocompromised are recommended to receive an initial series of COVID-19 vaccine and then at least 1 updated 2023-2024 COVID-19 vaccine dose. They may also receive 1 or more additional updated COVID-19 vaccine doses informed by the clinical judgment of their healthcare provider and patient personal preference and circumstances. Next. This slide shows the recommendations for those aged 6 months to 4 years. On the left, you can see that anyone who is unvaccinated is recommended to receive 3 doses. On the right, under the gray vaccinated box, you can determine how many doses are recommended now based on how many doses they received by manufacturer on the second row. Next slide. These are the same recommendations with the vaccines for 5 to 11-year-olds who are moderately or severely immunocompromised. Their recommendations are the same as those for 6 months to 4 years with one exception. If you look to the far right side of the figure, you can see that once the initial series vaccination is complete, for any additional doses, they can receive either mRNA vaccine. Next slide. Finally, we come to those 12 years and older who are moderately or severely immunocompromised, for which Novavax is also an option. The important thing I want to point out here is that Novavax does not have an initial series specific to those who are moderately or severely immunocompromised. So they have the same 2-dose initial series recommendation as for those who are not immunocompromised. But like the mRNA vaccines, they do have the flexibility to receive additional doses. Next slide. I want to end with providing a preview of our upcoming policy discussions. First on the horizon is the consideration of additional COVID-19 vaccine doses in older adults. We anticipate this discussion during the February 2024 ACIP meeting, and if we aim to bring that before ACIP at that meeting, the policy discussion will occur prior to individuals reaching 6 months since their last dose. Then we will pivot to preparations for future COVID-19 vaccine formula updates, with those discussions beginning at the June 2024 ACIP meeting. As always, we will be continuously monitoring vaccine effectiveness, vaccine safety, and COVID-19 epidemiology, and COVID-19 vaccine recommendations can be updated if needed. Next. In closing, I want to thank this incredible group that makes all of this work possible. Next. Thank you.
Thank you very much, Dr. Wallace. This presentation is now open for questions. Dr. Sanchez.
Thank you for that. It remains complicated, very complicated. But one question with the 6 months to 4 years, what if they have been vaccinated but not so-called up to date, and we don't know what vaccine they received? So in other words, if they received one dose of either, and they don't know which, or as it often happens, locations are only giving one. Like for instance, at Nationwide Children's, we only have Moderna. So if you don't know, do they get more doses? No.
Thank you, Dr. Sanchez. So we have a full appendix that lists all of the different iterations of things that can happen based on the number of doses that people think that they received in the past. But this is an area in which interchangeability is allowed. And so I think, at the very least, they would receive one updated dose. And I think that would be whatever is in their office at the time.
And if they've not been vaccinated, well, if they had not been vaccinated previously, they would require 2 doses of Moderna, 3 doses of the Pfizer. And so you don't know which one they received, or it's not available. Do you then give 3 doses? That was the old recommendation. Is that still applicable?
If you believe that they've received at least one in the past, I don't think we would recommend 3 additional doses. I think it would have to do with the age but they would, I think, at least receive 2 updated doses if they're coming in.
Dr. Sanchez, does that answer your question?
Sorry.
Okay, thank you. Dr. Paling?
So thank you for this presentation, and thank you for the clarification. You've clearly been listening to feedback and modifying the recommendations and the considerations based on this feedback, and that is really much appreciated. One of the points that we made is the vaccine coverage in young children, and there is a misperception that children don't get very sick with influenza. And so do you have any updated information on the hospitalization rate among children?
Thank you. If you can go to my first backup slide. So I think, the hospitalization rates among children are, certainly lower than what we see in older adults. But I think, if we consider them compared to other things, I think there's still a substantial amount of morbidity here. And, particularly those in the youngest age groups, less than 1, I think they have relatively, higher hospitalization rates, all things considered. And in particular, we're starting to see those rise as we move into the fall respiratory season. And I will also say on the line is Dr. Havers from COVIDnet, so if she wants to add anything, I defer to her.
Yeah, I think, so the data I think that's showing there is from the last year. And I think, as Dr. Wallace pointed out, that we still see the highest rates of hospitalization in very young infants, particularly among those less than 6 months of age. We have seen a rise recently, but as we've seen over the last couple of weeks, hospitalization rates have been declining, but we don't know what to expect over this next year. But I would say that very young infants and then school-age children have lower hospitalization rates than the very young infants. But as you can see on the slide, hospitalization rates by age group have been going up, but have started to decline recently.
Thank you. Dr. Cotton.
Thank you. So This is a general question, not so much on this specific talk, but perhaps actually relating to the last talk. These rates of revaccination or vaccination are really abysmal. And when I see patients, they're actually really confused. Many tell me that they're up to date, although their last vaccine was in 2021. They said, no, I had 3. You know, they're kind of, many are amenable to vaccination when I bring it up, but they are not necessarily knowledgeable, and I think there's a lot of confusing information out there. It seems like we could do a better job with just general education of the public. And I'm wondering if the CDC has plans for that. I think it's not clear whose responsibility that is, but from a public health perspective, I'm wondering if the CDC has a plan or anything they might be rolling out or any updates. Thank you.
Yeah, thank you for that comment. I mean, I think this season we have been really trying to focus on how to simplify and streamline all the information that is being shared with both the public and providers, because it's not just COVID and new COVID information, but RSV, which is brand new to everyone, and flu, and the timing, and the populations of interest. So we're really trying to take a little bit more of a integrated and comprehensive approach, but that would also include the COVID-19 information. So we've been working on a number of materials, both for the public, but also for providers. We've been putting out, provider toolkit, including additional clinical education resources to help make that more clear to the provider community. We've been continuing a lot of our communication efforts geared towards the public. We have some additional initiatives. So for example, with the Bridge program, communications campaigns, since educating that segment of the population that this program even exists and how to access it is important. So we have been trying to work through that this season, taking an integrated approach to the 3 vaccines that protect against respiratory viruses. But I think it's also, I think what we're learning through some of our surveys and other work that we're doing is, there's certainly a lot of vaccine fatigue in the public. There's also in the provider community a concern that patients don't want this vaccine, and if they bring it up, it could harm their ability to talk to them about other vaccines and things like that. So I think we're trying to not only approach it from education and supporting the public, but also supporting our providers in having those conversations and answering their questions and things like that. So.
Thank you very much for all that work you're doing. I guess there are members of the press who are listening, and I know that many of my patients actually get a lot of their information from outside of standard medical channels or CDC channels. So I would just encourage members of the press to convey appropriate information about vaccines, and that's yet another way. I think many people who signed up as journalists and whatnot didn't necessarily do so to save lives, but we've learned during the pandemic how important their role is. So for members of the press listening, please help us. It is a multi-pronged approach, and I appreciate the thoughtfulness on behalf of the CDC. Thank you.
Thank you. Dr. Daly?
Yeah, I would just add to Dr. Cotton's comments, and you said that so well, I really appreciate that. I just, taken a big picture view, 1,200 deaths a week from COVID. Those deaths are largely vaccine preventable. And if you haven't gotten a vaccine this fall, you're not adequately protected. And that's the message that I think we're all trying to convey. Again, 1,200 deaths a week, largely vaccine preventable. Get a vaccine this fall. If you could go back to slide 38, I think, for just a sec. So I agree with Dr. Paling that this is important, because what we were finding was we're transitioning to vaccination in the medical home by and large and other settings. And then those settings are probably going to carry just one of the 2 COVID vaccines for the practical reasons that Dr. O'Leary highlighted. It's so expensive, it's challenging. And so what we were finding was patients who would come to their medical home and then essentially be turned away because their medical home wasn't carrying the vaccine, the mRNA product specifically that they had received previously, and this was creating barriers. So I just want to thank everyone at the CDC who's worked really hard to change this language to a little bit broader language, and then thank our colleagues at the FDA. And I realize that this is both scientific and regulatory, but this is an example of the federal agencies and public health agencies working together to help remove barriers so that when somebody shows up, a kid in this case under the age of 5, they can be vaccinated. So a big thanks to you guys.
Thank you, Dr. Daly. Dr. Good.
Thanks, Dr. Lee. Thank you for a great presentation. I just have one potential suggestion. I love the infographics, but if there's any way to add the dosing intervals to there so you don't have to go to another place to sort of find that information would be very, very helpful.
Okay, thank you.
And then just one last smaller comment for me, which is as we're working on not only vaccinating our patients, and I will say, for whatever reason this year, we seem to have less hesitance than we've had in years past, but for the respiratory viral vaccines, let me just speak broadly about them. But one question I actually have is whether or not we're tracking data on healthcare worker vaccination. And the reason I say that is with the CMS mandate going down, I am very curious about uptake at the different institutions and whether or not there's a difference that we're seeing between flu and COVID, for example, in terms of healthcare personnel vaccination in order to protect the patients that we care for. Do you have any information on that? Or are we tracking on that going forward?
I know we annually monitor flu vaccination among healthcare workers through different sources. We do an annual survey of healthcare workers to assess their vaccination status, and I think we do ask about COVID in there. I think there is some monitoring of vaccination status of long-term care facility staff, and that is updated on our, I think it's the COVID net site. But I take your point about the importance of monitoring vaccination status among healthcare workers, and we can get back to you on that as well.
Yeah, thank you. It's an opportunity for us, partly because, we're caring for really medically fragile patients much of the time. And so to be able to make sure that we as healthcare providers are protecting our workforce and protecting our patients, I think it would be really helpful. And I will just say that since masking has gone down, we are certainly seeing more respiratory viral transmission happening in healthcare delivery settings since that has happened. So there were some benefits of masking, which is a lot of things got better. Okay, any other questions? All right, thank you so much to Drs. Daly, Stokely, and Wallace for providing this updated information on COVID-19 vaccines for the committee. We will move on next to pneumococcal vaccine session. Dr. Kobayashi will be, let me just confirm. I have Dr. Kobayashi providing work group updates and next steps. Is that correct? Oh, terrific. Thank you.
Good afternoon. Oops. Okay. Today, on behalf of the pneumococcal vaccines work group, I will present a brief summary of pneumococcal disease epidemiology and pneumococcal vaccines in development for adults. Oops. Okay. The pneumococcal vaccines work group reviews current data on pneumococcal disease burden and on the efficacy, effectiveness, immunogenicity, and cost-effectiveness of pneumococcal vaccines, and assesses the strength of evidence, reviews current pneumococcal vaccine recommendations considering up-to-date evidence, and develops revised or updated policy options for pneumococcal vaccines as needed. These are the current members of the work group, chaired by Dr. Catherine Paling, and Dr. Paling and Dr. Sarah Long are the two voting members on the work group. We also have the following ex officio members: liaison representatives, and consultants. And here are the CDC contributors and grade ETR consultants who support the workgroup activities. I'll start with a brief overview of the pneumococcal vaccine recommendations. Currently, there are 2 types of pneumococcal vaccines recommended in the United States. A pneumococcal polysaccharide vaccine, or PPSV23, that has been recommended since the 1980s, and pneumococcal conjugate vaccines, or PCVs. The first pneumococcal conjugate vaccine, PCV7, containing 7 pneumococcal serotypes, was recommended for children in 2000. And 10 years later, in 2010, PCV7 was replaced by PCV13, containing 6 additional serotypes not included in PCV7. PCV13 was the first conjugate vaccine that was recommended for adults in 2012. In 2021, 2 new pneumococcal conjugate vaccines, PCV15 and PCV20, were recommended for adults. These vaccines contain additional serotypes not included in PCV13 and were initially recommended for adults who had not received a pneumococcal conjugate vaccine or whose vaccination history is unknown. Later, the recommendation for PCV20 was expanded to include adults who previously received PCV13. PCV15 and PCV20 are now recommended for children. And as you can see, adult pneumococcal vaccine recommendations have been updated multiple times since 2012. Now I will briefly summarize pneumococcal disease burden in adults. Among adults of all age groups, there were an estimated 100,000 non-invasive pneumococcal pneumonia hospitalizations and 30,000 invasive pneumococcal disease, or IPD, cases, with 3,000 IPD deaths every year prior to the COVID-19 pandemic. Preliminary data show an increase in the number of IPD cases in late 2022 after reductions in IPD incidence across all age groups early in the COVID-19 pandemic. This increase was seen with other invasive bacterial infections, especially among children. This figure shows changes in invasive pneumococcal disease incidence among adults 65 years and older. The incidence of PCV13 type IPD is shown in purple, and IPD caused by all pneumococcal serotypes is shown in black from 2007 through 2021. Early in the COVID-19 pandemic, IPD incidence decreased across all age groups, and the incidence reached a historically low level. However, IPD incidence increased in 2022. This graph shows the distribution of pneumococcal serotypes that cause invasive pneumococcal disease in adults 65 years and older in 2018-2019 and 2020-2021. And approximately 40% of IPD cases were caused by pneumococcal serotypes not contained in any of the existing vaccines, shown in purple. There are new pneumococcal vaccines in advanced stages of development that are expected to provide broader serotype coverage compared with existing vaccines. The currently recommended vaccines PCV15, PCV20, and PPSV23 in the serotype coverage are shown on the top. There are 2 24-valent pneumococcal vaccines in advanced stages of development for adults. These vaccines provide comparable serotype coverage compared with PPSV23. The 21-valent vaccine at the bottom does not include some of the serotypes contained in existing vaccines, but does include 8 additional serotypes not contained in existing vaccines. And phase 3 trials in adults are currently ongoing. After a brief break in the summer, the pneumococcal vaccines workgroup will be reviewing evidence on use of 21-valent pneumococcal conjugate vaccine V116 for adults. Submission of a biologics license application for V116 to the FDA is anticipated in Q4 of 2023, with possible FDA approval in the first half of 2024. The workgroup plans to review evidence to support ETR domains, including epidemiology of pneumococcal disease among U.S. adults, assessment of pneumococcal disease caused by serotypes not included in V116, but included in existing vaccines, phase 2 and 3 clinical trial data on V116 among adults, feasibility and resource use involved in V116 used among adults, and health equity considerations. And we will aim to have an ACIP vote on policy options shortly after FDA approval of V116. This is the end of my presentation. Thank you very much, and I'd be happy to take any questions.